how to sort of wean them off these drugs?
Yeah. Testing is something that I very seldom or almost never do in these patients because it's, as I said, it's of no use. You can't really understand the outcome of the test. The second part of the question was how I deal with those who are already on multiple neuromodulators. These are the patients that I consult psychiatry to help me out sorting this out, which ones are of importance for their most often concomitant psychiatric illness or disease, and which ones is it that I would like to have them wean off due to their sometimes GI side effects.
Okay, fantastic. Thank you so much. So very pleased to welcome our last speaker of the session, Dr. Tariq Ahmed, who's consultant gastroenterologist at the Royal Devon and Exeter NHS Foundation Trust. He is the lead clinician for the Exeter Inflammatory Bowel Disease Service and honorary associate professor at the University of Exeter Medical School. And over the last 15 years, I don't have to say, I think everyone knows that the Exeter IBD research team has pioneered on many UK-wide studies investigating early diagnosis, prediction of treatment-associated adverse drug reactions, and optimizing and monitoring drug interactions. Thank you so much.
Thank you very much for the introduction. Right. So when we think about monitoring inflammatory bowel disease, most of us think about monitoring disease activity. But of course, we monitor many other things. We think about the impact of disease on the patient, on their quality of life and on their emotional well-being. We think about monitoring drug exposure, including adherence. We also monitor complications from the disease and complications from treatment. But with the rising prevalence of inflammatory bowel disease, and here are data from Exeter showing that we're approaching 1%, this feels an impossible task. Certainly in Exeter, this task is devolved to the inflammatory bowel disease nurses, but it's clear that we can't keep employing more and more nurses. We need to embrace advances in technology, and we need to empower patients to take part in this monitoring process. So what I'm going to do today is I'm just going to touch on each of these areas with a few examples which I hope you can take away with you. So I'm going to start by talking about monitoring disease activity. So, why are we monitoring disease activity? We're monitoring disease activity because Crohn's disease and increasingly ulcerative colitis are seen as progressive destructive diseases. Repeated cycles of inflammation and healing lead to damage, measured here on the y-axis with the Le Mans score. We also know that better long-term outcomes, here shown for ulcerative colitis, are achieved if you reach mucosal healing early in the disease course. This is data from the Ibsen cohort, 20-year colectomy rates stratified by mucosal healing at the end of a year. We all recognise, of course, that there is major disconnect between symptoms and endoscopic appearances. So if you treat on symptoms alone, you're likely to either under or over-treat your patient. And finally, we have lots of treatment options. So if one isn't working, move quickly on to the next. Endoscopy has been considered to be the gold standard for assessing disease activity, and the ECHO guidance and the European Society of GI Endoscopy recommend that in clinical practice we use a validated scoring test system for recorded disease activity. But colonoscopy is expensive, it's invasive, it's unpopular with patients. Here are some data from Leeds showing that 2/3 of IBD patients reported moderate discomfort during their procedure, and almost all of the patients would prefer a non-invasive test if that was available to them. Even with the falling endoscopy waiting times, most units still struggle with emergency additional patients added to their lists. And finally, despite the enthusiasm from many, use of endoscopic scoring systems is still not widely adopted in clinical practice, although I'm optimistic, and you'll see some of this at the meeting this year, that AI may soon help us out. So because of the difficulties with colonoscopy, most of us resort to using non-invasive tests, in particular fecal calprotectin. And I just show this slide here as a word of warning to you all. So here we have taken 50 surplus stool samples from patients, and we put them into their assay-specific extraction buffers and sent these samples, 50 samples, to 4 hospitals in the southwest. And you can see there is a massive range in the fecal count detecting test result returned by as much as 10-fold, even across this important working range of 50 to 250. So don't put too much weight on your fecal count detecting results. The other things that you could do is to maximise the utility of fecal count detecting testing, to make sure you use a single assay at a single laboratory. It's very important to calibrate your range in your patients and do a sample at diagnosis and sample at the same time of day. Now, patients tell us that they struggle getting hold of a calprotectin test when they need it. So why not allow IBD patients to request the test directly from the laboratory so that it's sent to them rather than them having to ring up the IBD nurse to request it? Another study from Leeds showed that 41% of requested tests were not returned in routine practice. And a primary care study from Gloucester shows that a number of factors which are associated with this, including embarrassment, concerns around hygiene, storage and transportation. So what can we do to improve fecal calprotectin return rates? We can provide instructions, and I was surprised to learn a few months ago that we don't in my own hospital. We can provide a stool collection device, here shown over the loo, to help patients collect the sample, and you might consider using a cone picker device identical to that used for FIT testing. We've shown it's preferred by patients and laboratories. They don't have to handle the stool. It allows immediate stabilisation of the calprotectin in the buffer and allows multiple samples to be processed simultaneously with a rapid turnaround result. The alternative to that is to consider point-of-care calprotectin tests, and many people here in the room will have experimented with these. Here's the IBD doc system. It uses a smartphone to capture the result, but it requires a motivated, dexterous, IT-savvy patient to action this. And for me, I would still prefer the poo through the post test using the buffer solution, mainly because I want to have one assay in my service. Moving now to interstitial ultrasounds. As a community, I think the UK have not been at the forefront of interstitial ultrasound for inflammatory bowel disease. I think this is access, training and time seem to be the reasons given for this, but there's also, I think, some scepticism amongst some of the gastroenterologists about the utility of this. But it's clear that interstitial ultrasound is as sensitive and specific compared to MR and CT, particularly when oral contrast is used. The 2019 ECHO guidance supports its use to monitor disease activity in response to therapy or drug de-escalation. It's very good at looking at extramural complications and for detecting post-operative recurrence. So in 2021, only 25% of UK hospitals have an IUS service. So my take-home message from this slide is consider attending one of the 12-month, 3-module hands-on courses, the first of which in the UK, I understand, is next month in London. So moving over to the impact of disease on the patients. Traditionally, this has been captured using a series of questionnaires, which are detailed on here: quality of life, fatigue, work productivity, etc. But these are cumbersome to use unless you can embed them directly into your EPR. And of course, by the very nature of them, they are subjective. So the idea FAST study that you may have heard of is looking to develop novel, robust digital outcomes, particularly for fatigue, sleep and activities of daily living. And this is using bed sensors to monitor sleep, EEGs, movement sensors, and your activity, your social interactions are monitored on your mobile phone. And if you think this is a long way in the future, well, it is actually already here in many hospitals in the UK, particularly those that are using Epic as their EPR. So questionnaires can be fed to the patient portal and completed by the patient. You can capture all of those questionnaires quite easily, and you can also link up many of these wearable technologies. And these are being used right now, particularly in acute medicine, to monitor pulse, blood pressure, saturations, peak flows for patients that are being managed acutely at home. Importantly about this, though, is all the data is fed directly into the EPIC record. Moving on to drug exposure, I'm just going to touch briefly on this, and this is the controversy surrounding proactive TDM for patients treated with anti-TNF. Because of a lack of evidence, or strong evidence, ECHO and the BSG have not endorsed proactive TDM for anti-TNF, but this has not stopped many enthusiasts from championing this, and they would argue that the poor study design or limited study design from which these conclusions have been made, together with the emerging paediatric data, suggests that we should be doing this. And they argue this is a low-cost, potentially cost-effective and safe therapy, so why not do it? And I would agree with that, certainly in the first year, where the risks of treatment failure and immunogenicity are at the highest. We hope that we will get the real answers to this in 12 or 24 months' time with the optimised study, which is comparing standard of care with proactive TDM-driven algorithm dosing in terms of frequency and concentration. But in the meantime, I would suggest to you that for your high-risk patients, that you do think about proactive TDM, maybe with a drug level as early as 6 weeks. Now, to facilitate this, you can either check a drug level immediately prior to your dose and then bring the patient back for an additional dose, perhaps at week 10, or you could use one of these near-patient tests, which provides, this is one from ProMonitor, providing a drug and antibody level in 20 minutes from the capillary blood sample so that you can dose in the infusion unit. TDM for other biologics still really doesn't have a place other than to explore adherence. Adherence is a major problem, as we know. Depending on how you define it, 40 to 80% of people treated with either tablets or subcutaneous therapy are non-adherent. You can consider asking patients to complete this MARS questionnaire, and a score of less than or equal to 23 highlights non-adherence at a rate of less than 9%. The alternative is to measure a drug level. For most of the biologics, this is now available, with the exception of B19s. You can measure methotrexate in blood, and you can also measure JAK inhibitor levels. And this might be particularly important for people with rapid transit or stoners. Last year at the BSG, Anjan Dar's group presented this data on a digital sharp spin, which reminds patients they need to take their dose, and if they don't, it sends a message to their healthcare team. And they showed in 45 patients on-time adherence rates of 76%. So in terms of when to monitor, here's my potential monitoring scheme. Highlights at the baseline here that I think it's worth, if you can, to collect the data, the PROMs from the patient, as well as measuring the CRP and fecal calprotectin. It's important to have an early assessment of response between weeks 2 and 6, and if they're not doing well, then try and optimise the situation if they're treated with anti-TNF or even early switch. Assess at week 14, and then again at the end of a year, completing the questionnaires again, so you've got some form of comparison. There are certain situations where you might intensify it, so after a dose change, following treatment withdrawal, and after surgery. So instead of intermittent monitoring, we're now entering an era of continuous monitoring. This is not far away, it's commercially available in the US. So this is monitoring CRP, calprotectin, TNF, IL-6, IL-8 from sweat. These recordings are uploaded to your mobile phone through Bluetooth and then submitted to your electronic health record. So this is already here. And these numbers now correlate reasonably well with serum levels. Moving on to disease complications, I just want to touch on one aspect, colorectal cancer surveillance. Considerable research is put into basic science and endoscopy research, but I think we're still not getting the basics right. And what I mean by that is offering all eligible patients a scope. At the top of the slide here, data from Exeter. This is hanging out our dirty washing paper. 42 patients with IBD eligible for screening who developed cancer. And when we look back at them, 64% had a missed opportunity for cancer detection. And 2/3 of these were actually in primary care. We'd lost them to primary care and they hadn't been offered surveillance. And then an earlier study from France, 54% of eligible people had not had a scope within the previous 7 years. So my take-home message here is make sure that you have an up-to-date registry of your patients across primary and secondary care. Don't wait until the solicitor's letter hits your desk as it did with me. So I want to touch on treatment complications as the last section here. And I've just got 3 examples that you may or may not have considered in the past. To start with, I wanted to mention skin cancer screening. So network meta-analysis and systematic reviews have consistently shown that non-melanoma skin cancer is associated with both current and past use of thiopurines. There's been quite a lot of controversy about melanoma, but I think based on very recent data from Denmark and from a big network meta-analysis, anti-TNF is not associated with melanoma. Well, here's the guidance from the BSG. These are the draft guidelines, which haven't been published yet. But these suggest that skin cancer counselling should be offered to patients who are treated with thiopurines or anti-TNF, and formal skin mapping by a GP or dermatologist if they've got additional risk factors. Now, these additional risk factors are not stated, but they might include fair skin, previous cancer, family history, occupational exposure. And in Exeter, that would be almost every one of our 455 patients treated with a thiopurine. The ECHO guidance suggests that people undergoing treatment with thiopurine should have skin cancer screening and take some protective measures. But there's lots of questions here. When are we going to do this? Are we going to do it before we start the treatment? There's some data from Austria that suggests we should. How often are we going to do it? And who is going to do it? And certainly when I've asked our dermatologists, they politely declined. But they have offered to train our IBD nurses. So it's another job for the inflammatory bowel disease. The second example I wanted to give, and you may not have considered this recently, but this is the issue of acute kidney injury occurring after ileostomy formation. So this is data from our surgical colleagues showing that acute kidney injury occurs in 1 in 7 patients following nasal GI surgery, including ileostomy formation, which is a specific risk factor. Importantly, acute kidney injury can occur after discharge, particularly with increasing use of laparoscopic surgery. So young patients can go home, they can develop a high outlet stoma and end up in trouble. And the problem is that it leads to readmission, increased 30-day mortality, but importantly, irreversible chronic kidney disease at 12 months. So what should we do? I think we should try and identify high-risk patients, and there's an online calculator there to help you. But simply, I think we should be sending patients home with the instruction that they have check blood tests and urinary sodium 7 days after discharge. Finally, in the last 3 years, we've had 6 new therapies for inflammatory bowel disease. And therefore, the onus is on us and our patients to report adverse drug reactions. And I wonder how many people have submitted a yellow card report in the last 12 months. I suspect it's very few. So you should download the app that's here and encourage your patients, when they're being counselled, to report adverse drug reactions, because these yellow card reports have made a difference. They've led to license dosing changes, and they've led to drug withdrawal over the last 10 years. So grateful if you could consider doing that. So to summarise, in 2 slides, use one calprotectin assay in your institution, delivered at one laboratory, and allow patients to directly request the test. They don't need to involve a middleman to get that. Provide instructions, use a home picker, or at least look at it, sample at the same time of day, and calibrate your patient at diagnosis. Do a test when they're unwell. Learn how to monitor with intestinal ultrasound if you feel you've got the energy and the time. Capture patient-reported outcomes. With an EPR, it's easy to do this, so do think about this. And for anti-TNF, I would advocate proactive TDM, certainly for your at-risk patients. Monitor adherence. Think about TDM for vedolizumab, ustekinumab. There'll be an assay for upadacitinib soon. If you've got any concerns either about rapid transit of tablets or adherence. Create a monitoring schedule and share it with your patients. Establish a local IBD registry for colorectal cancer surveillance. Think about how you're going to tackle the skin issue. I don't think I've got any answers for you yet. Send patients home with a blood test request 7 days after discharge and download the app. Thanks very much.
Thank you very much, Dr. Ahmed, for an excellent talk. Just in the interest of time, we'll just ask you a couple of questions, if that's okay. So with such extensive monitoring, do we not run the risk of disengaging patients through over-medicalising when they're simply craving normality? More is not necessarily better.
Clearly, we've got to bring the patients with us with this monitoring, but it isn't going to work unless we've got them on side. I'm not a great proponent of people recording their symptoms daily into an app. So I think patients want to forget about their illness particularly when they're well. But I think there are so many different facets to monitoring now that we need their help.
Okay, then last question. Unfortunately, drug therapy monitoring can vary quite a lot between hospitals. So in some you can get TNF level in a week, some in weeks. So even if you want to do proactive management, you can't. So do you have any thoughts about how we can improve this and standardise things?
Well, there are an increasing number of hospitals that are offering drug level monitoring across the country. There's currently 11 centres, and the volume of tests going through means that they should be able to turn around tests reasonably quickly. You can exert pressure on your laboratory and explain why you need the result quickly, or you can resort to one of the point of care tests which I alluded to. So I think if you haven't tried the point of care